Hello, everyone, and welcome to the latest global platform webinar on coronavirus and older people in low and middle income countries. And as you can see, in this webinar, we'll be looking at gender perspectives on these issues. Next slide, please, Lucas. In the early phase of the pandemic, it's possibly changed a bit since then, but, oh, that was a nice picture. But in the early phase of the pandemic, I would argue that there was rather more attention being paid to the ongoing and potential effects of coronavirus on women in low and middle income countries than on older people as a group. And I think this is a good example of that, an excellent policy brief that was published by UN Women on the effects of coronavirus on women, specifically in low and middle income countries. And just look at the date of publication there, the 9th of April. This is very early on in the development of the pandemic, particularly in low and middle income countries. And this very much is ahead of similar statements and documents that were produced with specific reference to older people. I think, although it was published several months ago, it stands the test of time in terms of the sorts of concerns that it identifies: specific economic effects on girls and women, that yes, the toll of mortality was higher for men than for women, but there were wider health concerns in terms of access to things like sexual and reproductive health services for women, concerns about an increased burden of unpaid care, and of course, issues like gender-based violence. This policy brief didn't really have anything very specific to say about older women or older people in general, but clearly some of these issues, particularly issues around domestic violence, are just as, if not more important, for people at older ages. Next slide, please. Of course, applying a gender lens to these issues isn't just about focusing on women, on older women, or looking at older women and older men separately. It's about trying to understand more complex social, relational dynamics, and we need to be able to situate these dynamics within specific contexts and understand gender as part of a wider story of intersectionality, different aspects of individual identity, including, of course, people's age. And we can use these sorts of gender perspectives in a whole range of different ways to help us understand what's going on. And just one example that I'd like to give you relates to some issues that I've been dealing with over the last few weeks. And this is related to the workforces in long-term care homes in low and middle income countries, although I think many of these issues apply equally in high income countries. This is a photograph I just found on Google Images, and I think it's from a nursing home in the USA, but it's pretty representative of what you might see in many other parts of the world, because of course we're looking at an almost entirely female workforce, although often the directors and the owners of care homes, particularly in low and middle income countries, tend to be male clinicians. Of course, as we all know, this is a workforce with very low status, low pay, low skills, very little social protection. And partly as a consequence of that and the casualized nature of these women are often required to work across several different care homes in the course of a single week or even a single day. And this is an issue that nobody really took much interest in until recently, when they realized that, of course, this could lead to cross-infection across care homes. Many of these workers are afraid to take tests or to report their status if they've taken a test, because of course they're not going to be paid if they don't show up for work, and they're living in very precarious situations. And of course, it goes without saying that these sorts of people have had absolutely no voice in or influence over the development of guidelines or protocols for long-term care facilities, which have been mainly developed by clinicians, both male and female senior clinicians, which I think is very unfortunate. So this is just one example of the need to factor more awareness of gender dynamics into our understanding of coronavirus and older people in low and middle income countries. And I'm sure we'll see some other very interesting examples in our talks and our discussion today. Next slide, please. One thing I always do in these webinars is just quickly give you some background on the status of the pandemic in the countries that we're going to be looking at. And to a certain extent, we see a lot of similarities across South Africa, Mexico, and India. We have large numbers of confirmed cases, large numbers of reported deaths. And in all of these countries, we see significant increases over time. So we see an upward trajectory. Next slide, please. For most of these countries, it's very difficult to get data which specifically looks at cases and deaths for older people and for men and women. Mexico is an exception in this regard. And here we have data from a couple of days ago, which show that among older people, a far higher share of deaths, reported deaths, occurred among men than women. But I actually find these data extremely dubious for a number of different reasons. One of them is that if you add up those two percentages, it shows that about 54% of reported COVID deaths in Mexico were people aged 60 and over, so 46% were people under 60. In Brazil, which has a very similar age profile, they're reporting about 74% of deaths, people aged 60 and over. I can't find any reason to explain the lower share of deaths among older people in Mexico compared to Brazil, other than far higher rates of underreporting of those deaths in Mexico. And this is increasingly something which is being recognized. This is a report in The Guardian a couple of days ago saying that, again, people are concerned about very high levels of underreporting of COVID deaths, particularly among older people. Next slide, please. And again, here we have data for South Africa, which, like Mexico, is able to provide data by age and by gender. But just, I think, yesterday on the main BBC news site, again, there were concerns raised about the reliability of these data, underreporting mortality, which have been particularly revealed by new studies providing data on overall excess deaths in South Africa, which show that the excess mortality is far higher than you would have otherwise expected. Next slide, please. So without going off on a tangent about data, I just want to emphasize that this is extremely important for all our analysis, including our analysis of gender dynamics. And it's an issue that the global platform is increasingly engaging with in a number of different ways. We have a policy brief about this, which you can see on our website. We've also developed a tutorial explaining how you yourselves can calculate robust estimates of excess mortality for people of all ages, and we provide an example of how to do that in the case of Peru. And the issue of data quality was the focus of our webinar, not webinar number 1, as it says here, I'm sorry, webinar number 11, our previous weekly webinar. So this is an issue which we feel, particularly as academics, we really need to engage with very closely. Next slide, please. So quickly, I'm sure you're all veterans of these weekly webinars, but I would just like to briefly hand over to Lucas, who will explain how we will handle collecting questions and comments from participants. Lucas.
Thank you, Peter. Welcome to all the participants. Questions can be made on the Q&A session. Also, we can use the chat box. And there is an alternative for those that are watching on YouTube. You can also put questions or comments there, and I will be looking at them. At the end of the 3 presentations, Janet will be handling the discussion and addressing the questions towards the panelists. Thank you.
Thanks, Lucas. And I think this particular image of an older man in India is particularly apposite for some of the discussions we may be having today about old age and masculinities. But without further ado, I would like now to hand over to Janet Seeley, who's a professor of anthropology at the London School of Hygiene and Tropical Medicine, and is going to be chairing the rest of this webinar. Janet recently co-authored an excellent paper, which I think came out in Lancet HIV, talking about lessons we can take from many years of studying HIV in sub-Saharan Africa and apply to the COVID pandemic. So she's somebody who I think will have tremendous expertise and knowledge, which will help guide this session. So over to you, Janet, and good luck.
Thank you, Peter. So I'm very happy to almost immediately hand over to Jane Simmons, who's going to be our first speaker. She's from the South African Medical Research Council, and she's going to talk about grandmothers. So Jane, you're welcome.
Thank you, Janet, and thank you to everybody. And wonderful to be on this this platform talking about something which is very close to my heart, and I think possibly very close to most of us. I think everybody at some stages has had a grandmother and knows the value of grandmothers in families and in individuals. Lucas, can we go on? Next slide. So I work at the South African Medical Research Council, and I've set up an NGO called Go Gogo Go. Now, a gogo is the local South African word that is used to refer to an older woman. It's a word of endearment, it's a word of affection, and it is a word of respect. So what I've been looking at is how we can work with gogos to empower them to enable improved health outcomes in themselves and in the children they are raising, their families and the communities that they live in, by mobilizing gogos as agents for health promotion. Just a few, I did a bit of background about myself. I did a master's in public health, and I based my research in a township outside Johannesburg called Alexandra, where I interviewed grandmothers about their experiences of talking to the children they were raising about sex and sexuality and HIV and AIDS. And these cartoon quotes that you see on the side are comments from the grandmothers that I interviewed. And you can see how they speak to the importance of the role that they see themselves as raising these children. Next slide. So, we have a problem in South Africa with 4 colliding epidemics: maternal, newborn and child health, HIV and AIDS and tuberculosis, and NCDs and violence and injury. This work started in this field of looking how can gogos help us with this. But we don't know how COVID is going to impact on this and what is the role of COVID going to be with this. Next slide, please. So we've got what I call our wellness tree. And if you look at in terms of wellness, if you are well or healthy, you are probably accommodated, you're probably educated, you probably have food security, you probably have good reproductive health, you probably have a job, you probably have good mental health, and you probably live in a safe and healthy environment. If you are have an NCD or a non-communicable disease, it is probably managed. If you have HIV or TB, those are managed. You have access to good healthcare and you have access to treatment. These all together contribute to making an individual healthy. And for me, health is your apex outcome. And if someone is healthy, all these determinants of health are accommodated. Next slide, please. So just to give you some background to health promotion and why we're looking at health promotion, and I think what's interesting to look at health promotion and COVID is that health promotion is usually linked to non-communicable diseases and hasn't really been used much with infectious diseases historically. But I think there is a very exciting opportunity for us to look at the role of health promotion in COVID. And I think what we've seen with COVID is that human health is not isolated. It is not an illness or disease is not something that happens in isolation. It occurs in a society, and we need to be prepared to react to illness or disease or infections that happen within our communities and in society. So if we look at health promotion, what is it? Effectively, it is keeping people healthy, and it costs less to keep healthy than to keep people healthy than to treat sick people. We have a program in South Africa for Vitality, which rewards people for being healthy. We look at South Africa implementing the NHI fund. It needs a healthy population to ensure its success. There's a real possibility of NHI funds being overwhelmed by sick people needing care. And health promotion needs to address the determinants of health. It needs to shift behavioral norms from waiting to get sick and seeking treatment and cure management to keeping people healthy to avoid needing treatment. Next slide, please. So we look at the determinants of health. These are the things that impact on health promotion. There are 70 new sustainable development goals. There's been a shift on focus from health outcomes to the underlying factors. There's been a shift in challenging purely biomedical notions of disease. The role of global and national political economies in creating health equities. We now are starting to look at the social determinants. What are the circumstances in which people are born, they grow up, they live, they work and they age, and the systems that are put in place to deal with illness. We need to look at upstream factors. Why are people getting sick instead of treating people who are sick? In particular, we look at social determinants of premature mortality in South Africa, which include poor housing, inadequate water and sanitation, a suboptimal food environment, high levels of alcohol and substance abuse, low levels of social cohesion, and inadequate health system response. Next slide, please. So with health promotion, with COVID, and we'll get on to the grandmothers here, is we're looking at behavior change and why do we need it? And we need to look at who are the gatekeepers and enablers to behavior change. What are our barriers to behavior change? And how do we sustain behavior change? I mean, how do we move from practice exclusive breastfeeding for 6 months, increased condom use, healthy eating, exercise, underage drinking, smoking, and now COVID? Who are the people who we can target to sustain this behavior change? Next slide, please. So I work with a model called the Social Behavior Communication Change Model, so known as SBCC, which looks at the role of 4 levels needed to capacitate change. We have an individual level, which involves knowledge, skills, benefits and values, self-efficacy, perceived norms, perceived risk and emotion. You then have your family and peer network, which is your peer influence, your spousal communication, your partner families and social support. There then is the community level of leadership, access to information, social capital, collective efficacy, and finally your social and structural level, which is leadership, resources and services, policies, regulations, guidance and protocols, religious and cultural values, gender norms, media, and technology. Next slide, please. This model uses something called the socio-ecological model for change. And it's based on these 4 levels in which we find ourselves living in a society. So there is yourself, where you have your own personal knowledge, your partners and peers. It's similar to the diagram I showed before, but the importance of this diagram is that I want to show you these cross-cutting factors of information, motivation, and ability to act, and norms. So if you have any of these 4 levels missing from this wedge, none of the behavior change that you are trying to achieve will not be sustainable or be maintained. So I can use the example in South Africa. We have a big drive to wear masks. Now you can have your own information to wear a mask. You know that to wear a mask is now mandatory in South Africa. So you have that knowledge. You are motivated to wear a mask because you believe that masks are important. However, your family or your friends tease you when you want to wear a mask. Our community and our organization, the leaders have said wear masks and leaders are wearing masks. But if you look at the community level, is the product of a mask available? Masks are not available to everybody in South Africa. And then finally, you have your enabling environment with your legislation or the laws or the rules that support the behavior that you are trying to change. Next slide, please. So why do we look at goggles? I've given you the background of health promotion. Why are we looking at goggles as health promoters? So research is showing that the role of goggles in developing countries is showing a very positive impact that goggles can make in supporting change in the area of social and health issues. We have goggles or grandmothers in all communities, and these are important resources of for care, income generation, parenting, and family support. Gogos hold a position of respect due to their age and communities through cultural and traditional practices. And in South Africa, Gogos are often the sole recipients of income in the family due to the older person's grant. Over 3.5 million children in South Africa are being raised by Gogos. And in some communities, 40% of children live with Gogos. Even if parents are alive, they are often absent from the households due to work hours, work location, or seeking work in other places. Next slide, please. Parents and caregivers are important in reducing the uptake of risky health behaviors, but caregivers need support in addressing risky health behaviors with children, especially in this time of social media marketing and cell phones. Parent programs for parenting skills are traditionally focused on biological parents. They either ignore Gogos or view them as an obstacle rather than a resource. But Gogos are responsible for the daily needs, emotional and health needs of children. As respected elders, Gogos are often regarded as a source of knowledge and wisdom in families and communities and central areas, but are often largely undervalued in community and family resources. They have the potential to become sources for health literacy in families, and there's growing evidence that involving Gogos can lead to significant improvements in infant and young child feeding and health and border development issues. And interestingly, Gogos are receptive to new ideas. Next slide, please. So there are a number of projects in South Africa that are aimed at working with Gogos. And I think COVID has given us an exciting challenge, and this is a new space for us all to be thinking of, is what is the role of Gogos in COVID and health promotion? And there's a dual role here. The first important role is recognizing the value or the importance of keeping Gogos healthy. We know that older people are more vulnerable to COVID, but if we look at the value and the strength and the child raising role that Gogos play in Africa and certainly in South Africa, and I'm sure in many communities, probably in Mexico and India, that these women have a very important role in the health of the children they are raising. So there are two things we need to keep in mind here. One is the Gogos' own health, and the second is the health and the behavior change in the children they are raising. So briefly, if we look at maternal health in Senegal, Uganda, Gogos have been important in supporting maternal health and through prenatal visits. In newborn health, they're supporting breastfeeding, health of young children. If Gogos support vaccinations, it's more likely the children get the vaccinations, nutrition. Extraordinarily, grandmothers have been very important in changing the cultural belief of female genital cutting or mutilation, because by targeting grandmothers as the recipients of interventions to limit this or prohibit this practice has been very successful. Gogos are being used in mental health, in the friendship bench, dental hygiene, early childhood development, HIV and AIDS, and also in South Africa, we've got a project where Gogos have been working with this walking bus. Next slide, please. Could we just play this video, Lucas? Is the sound working?
Just a second. I'm gonna try to make the sound work.
Bring the kids safe to school in the morning. because gangsters were shooting here in the morning at each other. So I stated the gangsters don't bother if it's daytime, nighttime, morning time or afternoon time. If they want to shoot at each other, they do it.
I like walking with a walking bus to school because they make me feel safe. When I used to walk by myself, I felt scared because someone is just gonna come behind you and take you away, and maybe they're gonna kill you or something. Every time when we go to school, walking bus make jokes and we laugh with them, and they ask us, are we alright? If we say yes.
Thank you, Lucas. We can go to the next slide here.
Yes, just a second, sorry.
So what is Go, 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 Go? And this is where we need to think about how we can work with grandmothers. How can we build their capacity? How can we support them? How can we recognize their role and give them value? And I think that video gives us a lovely entry into the role of grandmothers in communities. And I want to just look at the research I did for my master's and how we looked at the role of grandmothers speaking to children about sex and sexuality of HIV and AIDS. And I want to sort of translate that conversation and those thoughts into the role of grandmothers and speaking to children about protecting themselves from COVID. So in the video, which was obviously filmed pre-COVID, it's a couple of years old now. And sadly, children in South Africa, school has been suspended again for children in South Africa. But you know, if we can look at the role, and I almost wanted to open up to the floor here for questions, ideas, thoughts of grandmothers. I mean, we can see these grandmothers are saying here, I prepare them, I pack their lunchbox, it's my responsibility to look after them. You don't even know it's half of it. I work as though I've been hired, it won't be my house. We could go to the next slide. So what we've got is a group of 5 areas of action, and this all now need to look at how we can move through advocacy, legislative reform, demonstration project examples, research and training to work with these goggles in COVID reduction. Next slide, please. The demonstration projects that we look at aimed are different, the first 1,000 days of children, antenatal care, early childhood development, nutrition, substance abuse, sexual reproductive health, gender-based violence, and then looking at the goggles health in terms of their own mental health, depression, exhaustion, stress, anxiety, their own NCDs, hypertension, diabetes, and obesity, and then income generation projects. I'm going to stop there because I've got a message from Lucas that I've got 2 minutes left. You know, if we look at COVID and HIV, and just to compare them again, you know, and mask wearing, which I equate to wearing almost to condom wearing. How do we shift the behavior about not wearing a condom or not wearing a mask into becoming the new norm? How do the grandmothers speak to their children? How do they inform the children? Where do grandmothers get their information about COVID from? A lot of South African information is based on WhatsApp, smartphones. You know, I've done research on messaging to older people, and sometimes the font is too small for people to read. We need to look at how we can work with grandmothers as enablers of behavior change. And the video of them walking with their children to school, I sort of imagine if grandmothers could be providing masks on the walks, checking children on the walks. You see that little boy saying they make jokes and they ask us if we were okay. You know, these grandmothers have a huge role to play in South Africa. And looking at that role and working with them and their role in health promotion and how to support them as agents of health promotion to protect their own health and the health of their children, I think is a very exciting space. And I would like to engage with with people on this conversation and possibly following it, if people could please, give me thoughts and ideas about this. Thank you.
Jane, thank you very much indeed. So I think Jane has very cleverly posed questions rather than expecting questions. So if you have answers to Jane's questions, then please put them in the Q&A, but indeed also questions for Jane while we move on to Maria. And Maria Montero Lopez Lena is from the National Autonomous University of Mexico. Welcome, Maria. And Maria is obviously going to talk about poverty, gender, and COVID-19 in Mexico. So over to you, Maria. Thank you very much.
Thank you to you, Janet. So maybe Lucas could put on the screen my presentation, and then we can start. So I will appreciate your help, Lucas.
Maria, I think your presentation is already there. Please let me know if you don't see it.
Okay. Well, thank you, Lucas, and thank you, Dr. Lloyd, for inviting me. It is a great pleasure to participate in this webinar representing my university and specifically my discipline, psychology, and also to represent the university's interdisciplinary seminar on aging and older people, SUGEF. Next, please. Next slide, please. Okay, this is the sequence that I will follow. Essentially, I will try to describe what is the older person profile in Latin America and particularly in Mexico. What are the cultural, social, and economic conditions of older people in Mexico? And what can we do to improve the vulnerabilities that the Mexican older women cope with, specifically during the COVID crisis? The next, please. According to the World Economic Forum, in Latin America and the Caribbean, older people reach a little more than 76 million, from which 55% are women. This demographic evidence represents the first vulnerability in social terms that the older women have to deal with. Next, please. The economic reaction to increase the older people is a prejudiced and a biased thought. The basic notion of this tendency is considering older people as an economic burden. So the fast-track solution is to eliminate them. For those ideas, there is an irrational assumption that COVID pandemic is a genocide strategy to reduce the amount of older people. This is the negative side of the story. By contrast, next, please. The positive side is related with the gains that could be associated to life's older stage. Among the positive consequences of being older, the Global Future Council on Longevity suggested 6. For instance, if the older person belongs to the middle or upper class, more than being an economic burden, these people tend to donate their money and their time more frequently. At this stage of life, people look for enjoyment and spend not just money, but time in different places. So this activity can promote the tourist industry. In addition, older people look for a different option to live, so the real estate activities can be reactivated. Next, please. In Mexico, since the 70s, the government established a specific institution and program devoted to take care of older people. But unfortunately, until the second decade of the 21st century, the social impact of this program has been scarce. Next, please. Now, we will see some of the facts that contribute in different ways to the vulnerabilities of this population sector, and specifically to the women living in difficult conditions. In Mexico, just the 32% of older adult groups receive a pension, and less than 12% of those people are women. Next, please. Next. Regarding ethnicity, in Mexico, there are 68 indigenous groups that represent almost the 10% of our national population. From this amount, less than 1 million are older, and there are more women than men in this group. So, being an indigenous woman with low income represent another vulnerability and all that older women in Mexico have to deal with. Next, please. This profile represents also some consequences at psychosocial level. Women suffer more frequent and more diverse kinds of violence than men. Next, please. However, both of them present similar physical health profiles. Next. In terms of mental health, depression is the most prevalent disease and women are the most vulnerable sector. Next. The most prominent vulnerability among women is related to poverty. The feminization index by poverty shows that there are more women in regular and extreme poverty condition in urban areas as well as in rural areas. Next. Similar tendency appear when we consider the income per sex. All women live without formal income in urban and rural areas. Next. This evidence is ratified by the activity condition in people aged 65 and over. The women develop essentially house care activities and have less formal jobs. Next. According to a national survey following the effect of COVID-19 on wellness on Mexico households, 27.3% of Mexican adults have showed depressive symptoms and 32.4% severe anxiety symptoms. Regarding family care, women provide 79.2% of all care activities. Next. Regarding violence towards women, between February and March of 2020, 911 calls related to violence against women raised 22.3%. So our health policy of staying home instead of protecting women has put them at higher risk. Next. According to the official information available as of July the 8th, the case fatality rate for COVID in the population of 60 years and over is 1/3 in Mexico. Next. Regarding this profile with the COVID pandemic, it is interesting that a little more than 50% who have died were older people. From those, only 37.5% were women. So this fact could be appreciated in positive or negative terms. In positive terms, we could say that women have enough immunological reserve to cope to the SARS-CoV-2 virus. So women will survive this pandemic. In negative terms, the same fact of being a survivor implies that women will become more vulnerable. The accumulated vulnerability related to being a woman are associated to working mainly in house care, the economic weakness, the lack of formal income, and the discrimination for being part of an indigenous group. So, what can we do to improve women's condition and specifically older women's well-being? Next, please. Next. Here are some suggestions. To adopt a lifespan approach to health and well-being. This is a strategy to know which are the critical turn point turning point of being older, to recognize the Mexican cultural diversity and to promote its strength. This represents one of our richest attributes, and one of our biggest challenges is to preserve it. To promote mental health and physical well-being, incorporating cultural healthy tradition among indigenous groups. This means respecting traditional knowledge as well as scientific contributions. To make different ways to being old in Mexico visible. It implies identifying and recognizing the different ethnic groups in Mexico and the different vulnerabilities that exist among them. To adopt technology and design to be inclusive to people of all ages and groups, by optimizing the use of technology to reducing the digital gap and promoting health to everyone involved. To redefine caring activities inside of a family, within the community and at the government level. This means promoting house care activities equity. To engage multiple actors like governments, industries, communities, to create solutions to boost the impact of healthy expectancy. This means promoting co-responsibility of everyone involved in healthcare and promoting wellness in every single level. To promote our own models of community development, considering positive global initiatives on healthy aging, to provide recommendations to government, industries, and specific communities. This means to build two-way bridges between academia and stakeholders. Next, please. Well, next. Well, I ratify my acknowledgement to be part of this webinar, and it will be my pleasure to answer your question on this presentation, if any. Thank you.
Maria, thank you very much indeed. And thank you for being very prompt. So I'm happy now to hand over to Penny Verasanso, who is from the Birkbeck College at the University of London. And she is talking about COVID-19, gender and health in India. Thank you, Penny.
Thank you very much. Can you hear me?
Yes.
Yes.
Okay, great. Okay. All right, so yes. So I'll just say that this woman is working on the National Rural Employment Scheme, these two older women, and we'll talk about that in a minute. So if we can go to the slide, please. So I'm going to be talking about the sociology of health and illness, and I think we need to understand this to get the idea of the context and processes determining health access. And I'm going to focus on local people's experience. I've done the research, I've dragged it up, and now I'm giving you the story. So you won't actually have nice quotes as we did in Jane's work. And when I talk about older people, older women, I'm talking about poorer older women, women from poorer households. And when I talk about younger men, that could be middle-aged men or men in their 20s. So that's a sort of relative position. And the reason why I'm doing this is that to give the larger context is that I want to correct the tendency to extrapolate from concepts and experiences and expectations generated elsewhere or in other geographical areas or in class terms, even within India. So under the current regime, health access in India is tied to socioeconomic status. It's also tied to work access, and it's tied, as we will see, to the moral right to work. And older women are less able to assert a moral right to work than young and middle-aged men when there is a shortage of work. Okay, so if we can move to the next slide, please. So the political context, we need to remember that India isn't really a country in the way that say, European countries or countries. It's much more like America. It's a federated state. So talking about the India situation is frequently meaningless, has to be dealt with very carefully. There are 32 states and union territories in India, and they all have their own electoral politics. They're very diverse in terms of their economies and ecologies and demographies, and these may not fit well with union government policies. And so they implement them variously. They may not implement them at all. They may go much further than the union government requires, or they may implement completely different things. So the union government allocates resources to each state and union territory. It's done politically. The database is poor, and it's more about providing a share of the budget and deciding what share of the budget goes to each state over different groups of needs that are identified, but it's not about actually meeting need. It's about being seen to do something, but not necessarily do it. It gets, because it has to be implemented by local governments or state governments, it often gets union governments off the hook. So, and this can be seen in terms of the way the pension is delivered for, non-contributory pension, and that can be investigated if you like it. But in terms of health, for instance, for the context, the main form of data gathering in India is the National Family Health Survey, which is supposed to inform policy, but they exclude women from the age of 48 upwards and men from the age of 52 upwards. So we can see where the focus is there. So next slide, please. So in terms of the COVID context and looking at the spread and containment, the people who brought COVID into India were the flying classes, which is an Indian term generated in India. And so they've had a strict lockdown from the 25th of March to the 4th of May. And when there was internal movement began in the 4th of May. And so there are hotspots, and in those hotspots we have returned to lockdown. It's an incredibly strict lockdown. And Maharashtra, Uttar Pradesh, and Tamil Nadu are the states that are having the biggest problems for very specific reasons. And so in 1.3 billion people, there are 30,000 deaths. And the question is why? And we've raised the question about recording deaths. I mean, deaths are not well recorded anywhere in India, I mean, at any time in India. But at the moment, there is massive stigmatization around COVID. And people are being thrown out of their homes and so on. People are not being buried if they're thought to be a COVID death. So that is holding back the recording of deaths. But it is also worth noting that India is a highly segregated society. So there aren't as many places where the contact coming from the flying classes to the poor will actually happen. So which is why it's actually less than it is at the moment. Once people were chucked out of work in middle class houses, that cut the spread there massively. That people don't travel on the same transport, people don't go to the same school. So there's a whole load of areas where there isn't contact. People are on building sites and so on. They don't have contact with the middle classes, the flying classes that are bringing it in. The place where you get it coming in is through people who work with tourists. So the places that the sources of spread has been social context, where people have relatives in other areas and they've gone for weddings or religious meetings or whatever. Markets have been a real problem in Tamil Nadu and elsewhere because you get middle classes shopping in wholesale markets. So that has spread it into rural areas. But what is also happening is there's a lot of quarantining outside villages, of people are not being allowed into villages until they've had tests. And there's a lot of stigma, so people are struggling actually to get into the villages, having walked to them. But the main change that is happening, that the effect of COVID in terms of health, is in work access. So next slide, please. So if we look at the socioeconomic context, the key factor in health access is poverty and precarity of work. So over 90%, some people say 94%, of people are in the informal economy. And with COVID and lockdown, you've got older women are now being crowded out of work, and they're being made dependent. And there is also a significant lowering of household resources. So the scale of poverty in India can be seen by this National Food Security Act, which was implemented in 2013, where they they posited that people who were below the poverty line or in risk of being below the poverty line, cycling across seasons and so on, was 67% of the whole population, 75% in rural areas and 50% in urban areas. And these people should be getting public distribution of subsidized distribution, and even free actually during COVID, of food, but actually a lot of people are not getting it. So this is one of those, a law that isn't even implemented at a union government level because they're not producing the finances, but also the hurdles that people have to get to access it. Now, the first picture I showed you was of the NREGA, the Right to Work, which came out of a Right to Work campaign. And households are supposed to get 100 days, households, not individuals, households, 100 days of work. And this is paid at a rate that men don't go to because they usually have other better paid sources of work. And so older women do it, and they rely on it particularly in low seasons, in the agricultural season. So next slide, please. So here's an example from a booklet from Kerala, and here's an example of a woman who's doing the NREGA or NREGS, the scheme work, and she's cutting away. She's 75. She's working on this because her son has had an accident, and she's the main earner, the only earner in the household. Next slide, please. And here's another one, a 72-year-old that they highlight. The reference is below if you want to see it. The booklet's very interesting. She's working because, as she says, after a point in life, you cannot and also do not feel like asking for money from your children. And what's not said here, because it's assumed that everybody understands it, which is why she doesn't say it, and this is what people will say to you, is that point in life comes when your children have their own children. Okay, thank you. So you don't feel like asking for money if it comes away from the children, from your grandchildren. Okay, thank you. Next slide, please. The problem that women have, and particularly older women have, is that they don't have the moral clout to work as a social right. So they can't, if there's a lineup of people wanting work and a young man's there or a man's there, they will just be turned away and say, look, there isn't enough work for everybody. We'll give it to him. He'll have dependents. You and ask your son to look after you. So they don't have the same clout. So men do, and men are taking over women's work. And this is happening in rural and urban areas, as I'll show you in a minute. And it's forcing older women into dependence. And so the Ministry of Rural Development provides stats on NREGA. So this one, the first line is for a whole year. So it's 54% of women there were work days were the ones that women took on, and they took on an average of 48 days per household. But the legal requirement is that they should be given 100 days if they want it. So they're obviously not getting that. Now this one for 2021, this year starts in April, 1st of April. So this is in 3 months. The numbers of women who are women work days have dropped in 3 months, and 28 days have already been taken on average. If you talk to individual households, they're saying that they've nearly run out and they're only 3 months into the year and they don't know what they're going to do for work otherwise. So reports in newspapers are saying that male migrants are doing the NREGA. They have returned to their villages and are doing it, and including people who've got postgraduates, which is unheard of up until now, and people with degrees and so on. And also men are now working their own land, and they're not hiring in the fields because their sources of work have closed. They may have returned home. Or their sources of work locally, because they tend not to work in agriculture, they work in the rural economy or the urban economy. So, and what may be happening, I suspect that we'll find, if it's not already happening, is that men may be crowding older women out of agricultural work because they maybe start going for work that is considered either acceptable for men, or they'll just go for the work and take women's work. So older women are being forced into dependency. They won't ask for individual expenses, even for health, because there isn't the household doesn't have resources, and that's assuming there are nearby services, because a lot of rural areas there just aren't the services that people can access. So the result overall is we've got deepening hunger and deepening in ill health. Next slide, please. So if we look at urban areas, older women are being forced out of work by men again, and we've got increasing dependency again and less family resources and reducing access to health, although in an urban area you'd think there would be access to health. So older people, research I've done demonstrates that older people fill the economic spaces younger people have vacated for better opportunities. So the exact look at the labor market in different places will vary depending on what spaces are available for younger people, because the older people come in. So in some places like Chennai, which is India's 5th largest city and has a lot of industry and so on, men have moved into that work and opened up space for older women. So women take on the work that older men won't take as well, and so they tend to be at the bottom of the petty trading, the really small level stuff of petty trading. And as I've said, their work fits with the specificities of the local labor market. But with lockdown, men are being pushed out of work and they're not earning. And so what they're doing is they're moving into vegetable trading, which is where a lot of older women are located. And they're crowding out older women. And they're crowding them out either in street markets or by using these autos, and so that's a more capitalized ways of vending. And they're also using digital wallets, which allow people to use credit from their banks and gets over that whole problem of having cash. So next slide, please. So they're creating more attractive forms of selling. So this man here is a jeweler in Jaipur, and no trade as a jeweler, so he's diversified into selling vegetables using a flatbed auto. And the two guys down below are younger guys. One was a mechanic and the other one was an aluminium seller, and they're now pushing vegetable carts around Vijaypura in Karnataka, which is a smaller city. And there are people who are pushing these things, but older women can't push these things. Please move on. Next slide. Thank you. But what's also happening is that corporations are now moving in on vegetable selling. So you've got these ones, including Dunzo, who are funded by Google, and they're moving in on the vegetable trade. They're acting as middlemen between farmers and residents association, and providing online deliveries. Fixed prices, no bargaining, and all the rest of it. So, so it's becoming much more attractive, and this is where this took over from shops, but it's also taken over from street markets. And then the Greater Chennai Corporation have also felt that, taken this opportunity of shifting vegetable distribution, because they don't really like street markets. But they've been trying for 20 or 30 years to get rid of them. So, so they've announced 7,000 mobile units using tricycles and light cargo trucks like these, and which they're going to put into Chennai. This is just one city. And the Tamil Nadu Horticultural Department have also set up a mobile app of their own, linking farmers, food aggregators, and deliveries through Uber. So, you know, massive pressure on vegetable trading. Next slide, please.
Penny, you have 1 minute.
Oh no, okay. So these are the women who are just not able to compete, who were providing, you know, distributing for vegetables beforehand. So can we move on to before COVID? Move on to the next slide so I can just quickly get to the health thing. So, so in terms of health access, older people are not getting health access. And this is before COVID. And one of the main issues is that family resources, where they have the resources, are being put into education. So next slide, please. And health provision is actually incredibly difficult to access for people amongst the poor because it impinges on other people's incomes. So their families need to provide escorts to hospital. They need to provide 24-hour nursing. They need to provide food because the stuff isn't there. So that means for an older person to go into hospital, but also just to go and have an appointment, to have investigations, people are losing work. And it's not one person, it takes, you know, a network of relatives to cover the health needs of people to go into public sector hospitals and medical care. Next slide. This will be the end. So what happens is that people go to out-of-pocket expenses, and under the with women losing their independent incomes, they are not able to ask for money to provide for their health, and so they're just not, so they're losing access to the health. So what's happening is that losing access to work makes them dependent, and they are not able to fund healthcare, which they were more able to do, mostly going to pharmacies and saying, I feel like this, and they give them some, suggest some medicines that they can afford. That's not happening anymore. So we've got a decline in health access due to loss of work. And I think the next slide, we'll just skim it. So that's the conclusion. Gendered and age concepts that position younger men as having a greater right to work than older women, and a surer bet for credit. The lockdown has moved men into areas of work that older women have done, and the reorganization of vegetable production, distribution, etc., have all acted to undermine women's independent capacity to earn and to use the money that they get to allocate some of it to their health. Okay, thank you very much.
Penny, thank you very much indeed. So if I can now ask the panelists to put their videos on, please.
Oh, how do we do that?
Penny, don't worry, it's technically challenging.
No, it's all right.
Thank you. So we do have some questions, and just to keep me on my toes, they're between the QA and the chat. So please add any more questions to the QA. And I'm going to start with that QA question, which is actually for Jane, and it's quite a long one. So I shall read to you. It says, it's from Yen Utami Putri, and he says, sorry, I actually don't know the gender. I'm a GP from Indonesia. It's very interesting, this GoGo program, and I was wondering if it's applicable in another LMIC setting like Indonesia, since grandmothers in Indonesia are also practically raising grandchildren because parents are too busy. And as for how to inform these grandmothers, in Indonesia, grandmothers usually have a group of religious reading group which they meet regularly. So maybe we can use the meeting to have an opportunity to inform all the information they need to know and to do. Also, it's crucial to have a discussion about the info that's circulated via social media, because the elderly usually just accept all the information without knowing if it is good, bad, or true, or lie. I think there are a few things there. I think one of the things I was thinking was religious groups, church groups, and so forth are very important to a lot of older people in South Africa. So building on that question, if you have anything to say on that, and then also on the understanding of what is information to trust, and any comments on that.
Thank you. Well, I think Yane brings, apologies for not knowing how to pronounce your name correctly, but 3 important points. One, this is actually a global issue. So it's not even just low and middle income countries anymore. It's middle income and global north countries are also having grandmothers who are having a greater role in the raising of children while parents are working. So I think this is a program that should be and can be taken globally. Religious groups are a very important place to go. And this is one of the things we've looked at, is where are the old people? We find them in grant queues. We find them at clinics. We find them, like Penny was saying, selling little small stalls on the side of the road. We find them in church groups. And we have something in South Africa called a stokvel, which is like a saving club, where people meet every week and they put in their money, and at the end of the month, a different person gets all the money. So that's also a very powerful place to work. And then we've also, you touched on something which has become increasingly critical with COVID, is this fake news, or where do people get the information from? Because so much news has gone, or so much information has gone digital because of COVID. But even before COVID, older people seem to be scared of digital media and scared of the internet. And we actually want to do a study with one of the cell phone service providers in South Africa. Why are old people scared of the internet? Is it because it costs money? Is it because they're scared children will find porn? Is it because they don't understand how it will work, or people will steal their ideas or their money? We don't know. So, how do we empower older people to become the guardians of technology and internet technology, and make it their friend, and bring it into the household as an asset? And I replied back to say, please, could we carry this conversation on offline, because I would love to work with people in different communities in different areas. The questions are the same. We've got grandmothers who look after children. They tend, mostly probably love their children and care for their children. And we've got to find ways to support this.
Thank you very much. So I'm going to pose the next question to Maria. It's one that Peter has opened up, because building from Penny's presentation, the loss of work during lockdowns to younger people. So I wonder whether in Mexico, Maria, there's any comment on that, on what the circumstances are in Mexico, and whether older people have been disadvantaged because of lockdown or loss of work for younger people.
Okay, sorry, because my video said that the system is stopped by the hostess. So, but I'm here. Let me tell you that, okay, it's, yes, right now I am here.
Good,
so, great. So, yes, in Mexico it's interesting that the government assume that they don't force to the community to get their lock at their home, or to use military force to keep them inside of their home. But unfortunately, we have more than 50% of the people in lower of the level of poverty, so they have to go out. In this sense, the older people and younger people have to go out and look for the daily income. at the middle economic level, it is possible to keep the older people that locked down in their houses, but at the it's really similar the condition in Mexico and India also, because the poor people, they don't have any saving money to keep them inside of their house. Yeah, in that sense, is a big risk, the dissemination of the COVID disease. As a matter of fact, I see the amount of death in Mexico is higher than in India, even though in India they have much more population. So it seems to me that that is evidence that we have a lot of problems to make conscious to the population that this disease really is a risk disease. In that sense, that we don't have a similar profile for people who have enough money, the middle class and low classes, and in the low classes, and exactly also in the indigenous groups, they have to deal with many risk factors, specifically because they have to go outside and go and look for some income daily, in a daily basis.
Thank you, Maria. I was thinking that it's quite interesting in terms of South Africa. I was talking to a group of young people in KwaZulu-Natal just over a week ago, and they were saying that, and I'm putting this to Penny, they were saying, please, we need interventions for our grandmothers and grandfathers, because they are the ones who bring our money, because of, as Jane mentioned, because of the pensions. So I don't know if Jane, if you want to make any comment on that.
You know, this group, and it has, I think one of the aims of this group and these sessions that Peter set up is to make grandmothers or older people visible. And that's what I believe we should be doing, is we should be giving them a voice, we should be making them visible, and we should be mobilizing them. Grandmothers are not old anymore. I mean, 60 is not old anymore, and you've got a good 20 years to live after 60. So, and grandmothers can be 40 or 50. So I think it's very important to have programs that target grandmothers and older people in particular. They have very different parenting roles as older caregivers than a 30-year-old parent or an 18-year-old parent. And this was what I found in my research, is that there is a commitment and a love to these grandchildren, and a desire to take on new behavior to protect these grandchildren. And if I can just tell you the story of how I got into this work, I went to present at an NGO in Alexandra Township to a group of grandmothers on sexual reproductive health. And I thought, grandmothers, sexual reproductive health, sex, they're old. Anyway, I got there, they're not that old. And as I've got older, this was 15 years ago, I realized that older people also still have sex. But what happened was that the 70-year-old woman came walking to me with a baby on her back after my presentation, and she was crying. She was old and she was crying. And she said to me, please help me. And I thought, yeah. She said, please teach me how to speak to my grandchildren about sex. She said, I've lost 4 daughters from AIDS because I couldn't speak to them about sex. My grandchildren are now having sex, and this is my great-grandchild on my back. That I've been washing nappies for 60 years, so that I cannot, of diapers, so that I cannot wash diapers anymore. And that gave me the vision of the vulnerability and the exhaustion and the exposedness that these grandmothers are trying to live with and to cope, that they need They need the language to have these conversations. And I see Sajjad has asked me a question about sexual reproductive health communication. It's difficult talking about sex. It's very difficult if you're a mother. It's even more difficult if you're a grandmother. But grandmothers are showing that they want to deal with these issues and protect the children that they're raising, not only for their health, but also it's cheaper to have healthier children. And that ties in with the grant. I mean, grandmothers in South Africa get a grant of about $100 a month. And for some families, that is the only money in that household. And that household can have between 5 and 15 people in it.
Great, thank you. So I'm going to come to Penny, who's sitting, being very patient. Penny, I mean, I think that one of the questions that Peter had raised early on was those gender and masks. He was actually posing it to Jane, but I was thinking in India, in terms of distancing, in terms of mask wearing, in terms of hand washing, in terms of precautions, let's not talk about India, let's talk about Kerala or one of the states to try and make it manageable. Have you got any views on uptake of preventive behavioral interventions in India? Because, you know, people getting into business, being able to deliver vegetables and so forth, you may not know, but I'm just thinking in terms of people taking precautions if they are being in contact with anybody in the community, if they're the ones delivering things. Is there any sort of information drive or so forth to try and get people to be aware, or is it very top down saying stay home, behave yourselves?
Can I answer that question, and also one that Ken has posed, and that also relates to the one about the South Africa grant? So in terms of the masks and so on, I get the impression that, I mean, there is real fear in India, and that's how they've managed to do this, real fear. At the beginning, you know, they had marches and so on, which were just crazy when they had 1 day's lockdown and clapping and so on. But since then, there has been real fear, and there is real stigma. So in terms of providing vegetables and so on, there's quite a lot of people who are wearing masks and who are also wearing gloves. So there's a mix, right, of people who are doing different things. And if you want to sell to the middle classes, you're wearing masks and you're wearing gloves. So it's variable, which is, I suppose, the answer to that. But Ken asked the question about can cash transfers stop older people being forced into situations where they're working or they're not working, but they are getting some resources in order for medication and all the rest of it, which also came to the question of the grant in South Africa. In theory, these things are what's needed. Absolutely, totally behind that. The problem is the implementation. In India, the implementation, the pension is now just a political gimmick. It's been, I think the last time it was raised was 2010 in Tamil Nadu, 2007, I think it was in national level. It's not been raised. Inflation's running at 10% most years. It's not been raised. It's not worth anything now. It used to provide 20 days where people could sort of support, and people could maybe manage their workload and so on, but now it doesn't, and it doesn't provide for anything really. And nobody wants to get rid of it because at least it gives them 200 rupees or whatever, 400,000 now, I think, in Tamil Nadu. But the interesting thing is that the gender aspect and the age aspect comes into this, is that even when older people have resources, it's very hard for them, as the women said, I don't want to take resources from the family. So if they then become the source for resources, as seems to happen with the South African grant, it's very hard for them to hold on to those resources. It's also hard for people in India to hold on to it in those places where it's delivered once every 6 months, because it's actually a sum of money, or once every 12 months. So so pensions are the way forward, but there's how you do it.
Great, thank you. Now, there was a question about grandfathers which was posed to Jane, but I'm going to ask Maria, because one of the things I think is quite interesting is that there are gendered roles, and often, and I'm thinking in a lot of places, not only Mexico, but you've got older men who feel they have no place inside the house. It's women's territory. And I'm just wondering if you've got any comment on this question of, Jane's been talking about working with grandmothers. Is there a prospect for opportunities to work with men who perhaps are over 60, over 70 in Mexico, in terms of engaging them on activities to not necessarily address COVID-19, but to raise awareness, or if you like, going to what Penny has been talking about in terms of opportunities for creation of jobs and so forth. Any thoughts on that?
Yes, it's interesting, because we have a mixture of approach to combine the men and women roles, because in Mexico we don't have just one culture. We are all Mexican citizens, but it depends of what is your approach. If you are at the citizen environments, we have a specific profile, mixing the lower class and very, very, very wealthy people. And in this sense, we have to identify, it seems to me, some reference to talking about what is the role of men, or the opportunity of the usual men inside of the family. In general terms, I would say that we have at least 3 different kind of groups inside. The men can take some advantage. One of them is the upper class. Usually the upper class, the men has very clear their role, the social role. They are the authority, they are who take the decision, and usually the women work like dependents of this kind of profile of men. But at the middle class, the men I can see some changes, because the old age, the retired men becomes to be much more involved in the house activities. And if the marriage, because usually they are married, the couple works, they become to be more active as a grandfather, and is a very, very useful aid for the women. But at the poor level is different, because the men, as I told you before, the men and also the women have to go out and work and give money to the family. So it is not too easy to get involved and also to give some aid to the women. But one of the things that I want to share with you nowadays in Latin America is that the visibility of the old women is each more increasing, because we are moved from the dependency role to the much more active role as a women, and all women. In that sense, what Jane said about the go-go activities in Latin America and also in Mexico, we see the biggest aid that all women give to maintain the family in a good functionality, because all the partner or the young marriage has to go to work, and the goggles, also the women and men became to be support in functional terms to this young couple. So in that sense, it seems to me that we have to compare different factors that promote this interaction, intergenerational interaction, because we have different factors to aid and to contribute to these different roles, and to optimize these roles too. No?
Thank you, Veronica. Sorry, Maria. Veronica has raised the issue of intersectionality, which I think you've just talked to very, very effectively, talking about all of the different intersecting identities of older people. And I think that's a really important point to talk about inequality and ethnicity and race, etc., as well as age and gender. So we're nearly at the end, and I'm going to ask Penny if she would has any final thoughts she wants to share.
Yes, I mean, the thing about intersectionality is absolutely important. 15 minutes is not possible to deal with it. The situation of older men is very variable across classes, as was said about Mexico. One of the things that's quite interesting, talking to middle-class men, is that they have a real problem with trying to keep their families together and joint families and in groups. So bearing in mind that the care in old age is about having kept your family together. And one of the difficulties is that young men do not want to be answerable to their fathers. And that is the main source in middle classes of young men leaving and breaking up the family. So they can't talk about personal stuff. Maybe the mothers can, but the fathers fail. They have to keep distanced about it. In poorer households, the thing that breaks families up is actually whether the young people are working or not. And people will force younger families to split off because they don't want to be supporting them. So there's actually quite a lot of conflict within families in poverty. Poverty drives that conflict over resources. In middle classes, it's actually about status and being acknowledged as an independent person and being valued. So fathers will not play a role that can be seen as authoritarian. So different things are happening. You might be able to organize something outside, like Jane was saying about South Africa, but within family context, quite difficult. Lots of dynamics going on.
Great, thank you. So lots of really helpful points. So a big thank you to Jane, to Penny and to Maria for really fascinating talks. And I see Jane has been very busy answering comments. So thank you also for that. So I'm going to hand back to Peter just to give a final word.
Well, just to repeat Janet's thanks to our speakers, and to add also my thanks for Janet, who I think has done a brilliant job of chairing this session. Just one final word really before I talk about forthcoming webinars. And to me, a lot of what seems to be beneath this is a debate that's been going on for many years, which is I guess it's about intersectionality, and it's about particularly when as academics and as NGOs, we talk about older people. Do we make generalized statements about older people, about whether older people in South Africa share their pensions or not? Or do we talk about older women, grandmothers, widows? Do we differentiate between older men, those older men who are able to retain some kind of status of patriarchy within their social networks and their families, or those older men who often will find that their status declines very rapidly as the physical aspects of old age interfere with their ability to perform masculinities, to continue in paid employment, and often where they don't have the quality family networks that they haven't invested in those through their lives. And so I think these are some fundamental issues that we always have to be very mindful of. And when one talks about working exclusively with grandmothers, I'm very, very sympathetic to that approach, but are we actually working against gendered norms of later life, or are we actually reinforcing to some degree those gendered norms of later life? And is there some way that we could bring at least some older men within these strategies, or am I just being too idealistic there? And the dynamics within families and households, when you have a daughter-in-law who's responsible for caring for an older man whose status within that household has diminished in recent years, who's insisting that he washes his hands, that he wears a mask when he leaves the home, is he likely to be receptive to that kind of pressure? So I think there are all kinds of issues, and I think we dealt with some of them today, and I think there are many more that we need to consider as we continue to look at how these appalling pandemics play out across low and middle income countries. So just a final quick word, we're probably going to have another webinar towards the end of August, although I'm mindful that a lot of people have got other plans, particularly in the global north in the month of August. It may get pushed back to early September, and the preliminary topic will be, what role can gerontology and gerontologists play in addressing this pandemic in low and middle income countries? On one hand, of course, that's obvious, but on the other hand, as a discipline and as a collective group of academics, are we being sufficiently vocal? Are we able to make sure that our valuable expertise is being applied in the ways that it should be in the context of this pandemic? We're also open to other people's suggestions for webinars. So on our website, you will find a link. If you have ideas, if you know of people who may be interested in giving talks, we're very open to those suggestions. So please feel free to send us your own proposals or ideas. Well, that's it for another webinar. Final slide, please. I would just like to, again, thank our three excellent speakers, Maria and Jane and Penny, and particular thanks to Janet Seeley, who did a fantastic job chairing and managing the session, and also thanks to Lucas Sempe and Harsh Vasani and many other people, and to UEA, which gives us a little bit of money to keep this site going. Stay well, stay safe, and see you again soon. Goodbye.
Bye.